Welcome back to Rad-On Smart Review, the head and neck edition. I hope you are ready, because I am putting myself directly in the hot seat today.
And I'm ready to keep you there. Welcome, everyone, to episode 25, Nasopharynx Capstone Mock Oral Boards.
Yeah, so we're shaking up the format a little bit. Usually we're, sifting through data, taking our time. Today, we are simulating the pressure cooker, a full mock oral board session.
That's right. I'll be the examiner.
And I'll be the examining.
And the goal here isn't just reciting facts. It's about judgment. I want to hear your decision-making process, how you defend a choice.
For everyone listening, here's how it's going to work. We have 4 clinical blocks. Each one's going to get a little harder. We'll go from workup to staging to the really tough treatment planning choices.
And each block has a twist. Just when you think you have it figured out, I'm going to throw a complication at you, a real-life curveball.
So for you listening, try to treat this like a live exam. When you hear the case, maybe pause for a second. Think about your own answer before you hear mine.
Exactly. This is high-stakes focus. Let's just get right to work. Block 1.
I'm ready.
Okay. Block 1. T1N2, standard NPC, the definitive CRT pathway. Your patient is a 45-year-old Chinese man. He comes to you with a 6-week history of bloody nasal discharge and right-sided hearing loss. He's an immigrant from Guangdong province.
Yeah.
You do a nasopharyngoscopy. It shows a 1.5 centimeter mass in the right fossa of Rosenmüller. Biopsy confirms it. Non-keratizing undifferentiated carcinoma, EBV-encoded RNA positive.
Right. So this is a classic endemic presentation. The fossa of Rosenmüller is, the most common spot. And the hearing loss. That's probably the mass blocking the eustachian tube.
Correct. Now for the imaging, MRI shows the mass is confined to the mucosa. No parapharyngeal extension, no skull base involvement.
Okay, so contained.
But the neck is involved. There's a 2.5 centimeter right level 2 node, a 1.8 centimeter right level 3 node, and there's also a 1.2 centimeter left level 2 node that is FDG avid on the PET scan.
Okay, so bilateral.
Bilateral. All nodes are above the caudal border of the cricoid cartilage, no distant mets, and his plasma EBV DNA is 5,500 copies per milliliter. First question. Stage this patient using AJCC 8th edition.
Okay, so let me break this down. First, the primary tumor, the T stage. The MRI says it's strictly confined to the mucosa of the nasopharynx. So there's no parapharyngeal extension, which would be T2, and no bony involvement, which would be T3. So this is a T1 primary.
Okay, T1. What about the nodes?
The nodes, this is where MPC is. It's unique. The AJCC 8th edition defines N2 as bilateral cervical lymph nodes above the caudal border of the cricoid.
And this patient?
He has right-sided nodes and a left-sided node, so that's bilateral disease. We said they're all above the cricoid, and the largest is well under 6 centimeters. So that is, by definition, N2.
So the final stage?
T1, N2, M0. That groups to stage 3.
Correct. And that's the first teaching pearl. In NPC, N2 is all about bilaterality above the cricoid. Now, just to be clear, if this were an HPV-positive oropharynx cancer, would bilateral nodes automatically make it N2?
No, not at all. That's a key difference. In HPV-positive oropharynx, clinical N1 can include bilateral nodes if they're small.
And not here.
Not here. In NPC, the second you cross the midline, you're upstaging to N2. It just reflects a higher risk profile.
Exactly. N1 is strictly unilateral or retropharyngeal. The moment you're bilateral, you're N2. Perfect. Now, quick question on biomarkers. The referring physician calls you, asks why you haven't ordered P16 testing. What do you tell them?
I'd respectfully explain that P16 testing isn't indicated here. It's irrelevant for NPC.
Why?
Because P16 is a marker for HPV, human papillomavirus. That's what drives oropharyngeal cancer. This patient's cancer, especially given his background, is driven by EBV, the Epstein-Barr virus.
So what's the relevant biomarker?
The one we already have, the plasma EBV DNA. His is elevated at 5,500, which correlates with his disease burden. P16 status doesn't change anything for him.
Correct. NPC is an EBV disease. Don't get confused by P16. Okay, next question. What is your treatment recommendation for this stage 3 patient?
My recommendation is definitive concurrent chemoradiation. This is not a surgical disease.
And the systemic agent?
Cisplatin. My preference is 100 milligrams per meter squared, given every 3 weeks during radiation.
Is that the only option for the cisplatin?
No, you could also use a weekly schedule, 40 milligrams per meter squared. It's often better tolerated, but the high-dose bolus has, the most robust historical data. So that's my starting point.
And what about induction chemotherapy? Would you consider it?
For this particular patient, no, I would not.
Why not? He's stage 3. People here locally advanced, they think, induction?
He is stage 3, but you have to look at the anatomy. I reserve induction chemotherapy for two main scenarios. First, for really bulky T4 disease, where you need tumor shrinkage to get it away from, say, the brainstem.
Okay.
And second, for N3 disease, where the risk of distant mets is just extremely high. This patient has a small T1 primary and N2 disease. The added toxicity of induction just isn't justified here. Concurrent chemoradiation is the standard.
Good. It's an anatomy-driven decision, not a reflex. But let me push you. The EBV DNA is 5,500. Does that number alone trigger you to add induction?
No, it is not.
Explain.
The EBV DNA is a fantastic prognostic tool. It's a liquid biopsy. But we don't have level 1 evidence to say a specific number should trigger treatment intensification like induction in a T1N2 patient. I treat the stage and the anatomy. The DNA level just tells me to watch him very closely.
Correct. Treat the patient, not the number. Okay, now walk me through your target volumes for radiation planning.
I'd use a dose-painted IMRT technique over 33 fractions. The high-dose volume, the PTV70, gets 70 gray. That covers the gross tumor, the nasopharynx, and the involved lymph nodes.
And your intermediate risk volume.
That covers the entire nasopharynx, the skull base at risk, bilateral parapharyngeal spaces, and the critical part here, the bilateral retropharyngeal nodes.
Even though the imaging was negative for retropharyngeal nodes?
Yes.
Yeah.
Absolutely. The retropharyngeal nodes are the first station of drainage. You have to treat them. Leaving them out is a classic geographic miss. It's mandatory coverage.
Excellent. You avoided the trap. RPN coverage is always required. Okay. Here's the twist. Patient finishes treatment, does great. His 3-month post-treatment PET scan shows a complete metabolic response, looks perfect.
Great.
But you check his labs. The plasma EBV DNA is still detectable. It's down, but it's sitting at 1,200 copies per milliliter. What do you do?
Okay, so that's a high-risk situation. Persistent EBV DNA is a very strong predictor of recurrence.
So you start chemo.
No. As much as I'd want to, the data isn't there. There was a randomized trial that looked at this exact scenario, giving adjuvant chemo based on persistent EBV DNA, and it showed no survival benefit.
So what's your answer?
My answer is intensified surveillance. I would repeat the EBV DNA in 4 to 6 weeks. I do a very careful nasopharyngoscopy, get a dedicated MRI of the skull base. I watch him like a hawk, but I do not start adjuvant chemotherapy based solely on that number.
Spot on. Intensify surveillance. Do not reflexively treat the number. That's the correct answer. Let's move on. Block 2. T4N2 skull base abutment OAR trade-offs. Your next patient is a 52-year-old Vietnamese woman. She presents with diplopia and right facial numbness.
Okay, so cranial nerve symptoms right off the bat.
Yes. MRI reveals a 5-centimeter mass. It's invading the clivus, involving the right cavernous sinus, and there's perineural spread along V3.
Wow.
And critically, the tumor is 2 millimeters away from the brainstem. No frank invasion, but it's close. PE shows bilateral 2 and 3 nodes. Largest is 3 centimeters. Her EBV DNA is very high. 85,000. Stage this patient.
This is a heavy case. For the primary, she has intracranial extension with the cavernous sinus and clear cranial nerve involvement. That's an automatic T4.
Right.
Nodal staging, again, bilateral nodes above the cricoid, that's N2. So
Yeah.
T4, N2, N0, this is stage 4A.
Correct. T4 is defined by that intracranial spread. Now, treatment. Would you recommend induction chemotherapy for her?
Yes. For her, absolutely.
Justify that. You said no to the last patient?
Because the anatomy is completely different. There are 3 reasons here. First, anatomic. That tumor is 2 millimeters from the brainstem. I needed to shrink to create a safe margin for radiation.
Makes sense.
Second, her risk of distant disease is huge. T4, N2, and an EBV of 85,000. Induction addresses micrometastatic disease right away.
And third?
Third, we have data. Randomized trials showing a survival benefit for gemcitabine cisplatin induction in exactly these locally advanced cases. So
Yeah.
Gem-cis induction is my recommendation.
Excellent justification. Now, let's fast forward to planning. Your dosimetrist presents a plan. The PTV coverage is great, 96%.
Mhm.
But the brainstem D0.1 cc is 56 gray. Is that acceptable?
No, not acceptable. Absolutely not.
Why? You're covering the tumor.
Because the brainstem is a priority 1 organ at risk. You can't overdose it. The consequence is necrosis, which is catastrophic. It's a fatal toxicity. Safety over coverage for priority 1 structures, period.
So what's your instruction?
Reoptimize. Clamp the brainstem dose down. I will have to accept intentional PTV undercoverage right at that interface. I'll document it, but the compromise happens at the PTV margin, not the OAR.
Correct. That is the only safe answer. What is your specific brainstem constraint?
I use a hard max of 54 gray to the brainstem planning risk volume. The entire PRV has to be under 54 gray.
Good. Now, this tumor involves the cavernous sinus, which means the temporal lobes are getting dose. How do you counsel her on temporal lobe necrosis?
This requires a very specific conversation. I would tell her that because the tumor is next to the parts of her brain that control memory, the radiation has to go there to cure the cancer.
Then the wrist?
I'd say there's a real risk, maybe around 10 to 15% in her case, that a few years from now she could develop injury to that brain tissue. It's called temporal lobe necrosis. It can cause memory loss or even seizures. Serious risk we have to accept.
Very good. You quantified the risk and explained it clearly. Here is the twist. At tumor board, the neuroradiologist takes another look. She says, you know what? There isn't a 2-millimeter gap. I see a 1-millimeter point of contact with the brainstem. How does this change your management?
It makes the situation even more challenging, but the principle, the hierarchy, is the same. Brainstem protection is still number one.
So what do you do?
I know I'm going to be underdosing that point of contact at the beginning of treatment, so my strategy shifts to an adaptive approach.
Explain what you mean.
I'll start treatment with that firm brainstem constraint of 54 gray. Then I'll plan for a rescan and an adaptive replan around week 3 or 4.
And the goal?
The goal is that the tumor will shrink. These tumors are very radiosensitive. If it pulls away from the brainstem by week 4, I can then boost that area in the second half of treatment to get the full dose in, but only once it's safe. I don't start by blasting the brainstem.
Perfect. Contact triggers adaptive planning. Protect the stem first, then adapt. All right, let's move to block 3, post-CRT equivocal PT. Your patient is a 48-year-old man, 10 weeks after finishing chemoradiation for a T2N1 tumor. His post-treatment EBV DNA is undetectable.
Okay, that's a great sign.
It is, but his PET scan shows an SUV max of 4.2 at the primary site. It's down from 12.5, but it's not 0. The MRI shows some 8-millimeter soft tissue thickening. The report says, cannot exclude residual disease. Is this a complete response?
It's equivocal. I'm not calling it a failure yet.
Why not?
The timing. He's only 10 weeks out from radiation.
And why does that matter so much?
Because at 10 weeks, there's a huge amount of post-radiation inflammation. Those inflammatory cells are metabolically active. They take up glucose. So a PET scan this early is incredibly prone to false positives. You're likely seeing the glow of healing, not the glow of cancer.
So what's the rule?
The standard is to wait a minimum of 12 weeks, 3 months before that first response scan.
Okay, so the patient is in your office. He's anxious. He sees the report. He asks, doctor, do I need a biopsy right now? What do you tell him?
I have to de-escalate. I'd say this is actually a very common finding. The best news is that your EBV DNA is undetectable. That tells us the biology of the cancer is likely gone. This glow is probably just healing.
And the plan?
I do not recommend a biopsy right now. It can cause more damage and might not even give us a clear answer. The safest plan is to wait 4 to 6 more weeks and repeat the imaging. We watch and wait.
Correct. Don't overcall the PET at 10 weeks. Don't biopsy inflammation. So you wait. It's now 16 weeks total. You repeat the PET. The SUV max is risen to 5.8. Now what?
Okay, now the story has changed. Rising metabolic activity is very concerning for recurrence. Inflammation should go down, cancer goes up. Now I need tissue. I'd schedule him for an examination under anesthesia with directed biopsies of that avid area.
Excellent. The rising SUV is the trigger. Here is the twist. The biopsy comes back positive. Residual non-keratinizing carcinoma. The treatment failed locally. What's the next step?
Okay, we're in the salvage pathway now. First, I have to restage him completely to make sure it's only local. MRI, full body imaging, EBV DNA.
Assuming it's isolated to the nasopharynx.
Then the decision tree is it resectable or unresectable? My first call is to a head and neck surgeon to evaluate him for an endoscopic nasopharyngectomy.
Why surgery first? Why not reirradiation? You're the radiation oncologist.
Because the evidence is clear. For resectable recurrence, we have randomized data comparing surgery to reirradiation. Surgery had significantly better overall survival and much lower treatment-related mortality. Reirradiating the skull base is incredibly toxic. If a surgeon can get it out, that's the standard of care.
Perfect. Surgery is greater than reirradiation for resectable recurrence. Which leads us into our final block, block 4. Recurrent NPC salvage and knowing when to say no. New patient. A 55-year-old woman treated 18 months ago. Now she has new ear pain. Her EBV DNA has spiked to 9,500. Biopsy confirms a 2-centimeter recurrence in the nasopharynx.
Okay.
MRI shows it's confined to the nasopharynx, no skull base invasion. But it's sitting 6 millimeters from the internal carotid artery.
Close?
The surgeon feels it's not resectable, so you're left with reirradiation. What technique do you use and why?
If I have to reirradiate, I'm using hyperfractionated IMRT.
Explain that, the technique and the data.
Hyperfractionation means giving smaller doses more frequently. So instead of 2 grays once a day, I'd give something like 1.2 gray twice a day to a total dose around 65 gray.
And the evidence for that?
It comes from a randomized phase 3 trial that compared this twice-daily approach to standard once-daily treatment for recurrent NPC. Hyperfractionation improved overall survival and, just as importantly, it significantly reduced severe late toxicity and treatment-related death.
Why does it do that?
It's about sparing normal tissues. Those late-responding tissues, like blood vessels, have more time to repair damage between the smaller, twice-daily fractions. It improves the therapeutic ratio.
Good. Now this patient asks you, doctor, what about the risk to my brain this time? What about temporal lobe necrosis?
I have to be extremely honest. I would tell her the risk is much higher this time around.
Yeah.
And it happens faster, maybe within 1 or 2 years instead of 5. The risks of brain necrosis, soft tissue necrosis, bleeding. They are significant. It's the high price of trying for a second cure.
A necessary and honest conversation. Here is the final twist. While she was being evaluated, the surgeon ordered a new high-resolution scan. It shows the tumor has grown rapidly. It is now encasing the right internal carotid artery. 360-degree encasement. Surgery's off the table. Do you offer reirradiation now?
No, I do not.
But why not? It's her only chance for a local cure.
Because carotid encasement changes everything. It's a setup for a fatal carotid blowout. If I radiate that tumor and it shrinks, it will pull away from a vessel wall that has already been damaged by the first course of radiation. The risk of a massive fatal hemorrhage is just exceptionally high.
So you're saying the treatment could kill her faster than the disease?
Exactly. And the rapid growth suggests this is aggressive biology that local therapy probably won't control anyway.
So what do you offer her?
I offer systemic therapy. Platinum-based chemo, maybe with immunotherapy. The goal shifts from curative to palliative. Okay. We try to control the disease systemically. Sometimes the most important answer is to say no to radiation.
Outstanding. That is the critical skill. Knowing when not to treat is just as important as knowing how to treat. You've survived. Now for the Rapid Recall Pearls Blitz. I give you the concept, you give me the one-sentence, board-safe answer. Ready?
Ready.
INT 00099.
Establish concurrent chemoradiation. NPC is a radiation disease, and cisplatin improves survival.
EBV DNA utility.
It's the liquid biopsy. Pre-treatment levels predict risk. Post-treatment clearance predicts cure.
Residual EBV post-treatment.
It triggers intensified surveillance, not reflex adjuvant chemotherapy.
Indications for induction chemo.
It's anatomy-driven for bulky T4 skull-based disease or high-risk M3 patterns.
Priority 1 OARs.
Brainstem and optic structures are inviolate. I accept PTV under coverage to spare them.
T4 temporal lobe necrosis risk.
Low double digits. Counsel explicitly on memory loss and seizures.
Response peak timing.
Wait at least 12 weeks to avoid false positives from inflammation.
Salvage for resectable recurrence.
Surgery is preferred over reirradiation due to better survival and less toxicity.
Reirradiation technique.
Hyperfractionation is preferred to improve the therapeutic ratio.
Carotid encasement recurrence.
It's a contraindication for reirradiation. Refer for systemic therapy.
And stop. That completes the Nasopharynx Capstone. You navigated everything from the standard case to the absolute toughest call.
That was intense, that carotid case.
Yeah.
It really drives home that just because we have the technology to treat something doesn't always mean we should.
Exactly. The boards are about decisions. Defend your choice, hold your ground on safety constraints, and know when the biology has outpaced your tools.
I hope I passed.
You did very well. For our listeners, if you want to practice more of this, you can go to radoncsmartlearn.com. Next time we're moving down, episode 26 will be the larynx block. We'll get into anatomy, staging, and the whole philosophy of organ preservation.
I can't wait. Thanks for tuning in to Radon Smart Review.
We'll see you next time.